Cowdley, on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled Test Your Knowledge, an interactive session on emerging data and expert insights on hepatitis B. Today's program is supported by an educational grant from Gilead Sciences. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for both ABIM mock points and as CME for MIPS improvement activity. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation, as you know, and CME Outfitters will be pleased to submit your mock points for you. And to claim this activity as CME for MIPS improvement activity, complete the survey that you'll receive from CMEO in approximately 3 months and provide examples of changes you made to your practice, and CMEO will send you confirmation of your participation, which you can submit to CMS. So as I mentioned, I'm Chris Cowdley, Director of the Liver Institute Northwest and Clinical Professor at Elson S. Floyd College of Medicine at Washington State University. I'm very happy to welcome two friends and colleagues to the program today. Joseph Lim is Professor of Medicine and Director of Clinical Hepatology in the section of digestive diseases at the Yale Liver Center at Yale University School of Medicine in New Haven, Connecticut. Welcome, Joe. I'd also like to welcome Grace Wong. Grace is a family physician at the International Community Health Services and clinical instructor in the Department of Family Medicine at University of Washington School of Medicine in Seattle, Washington. Welcome, Grace.
Morning.
So let's begin with our first learning objective, to implement routine screening protocols for hepatitis B in the primary care setting to derive guideline-directed care. So the global viral hepatitis strategy impact targets for elimination has pointed out that the goal should be to reduce from 6 to 10 million infections to 900,000 by year 2030, and to reduce from 1.4 million deaths in 2015 to under 500,000 by 2030 for hepatitis B. Now, HBV is a vaccine preventable disease, but vaccination rates are concerningly low among adults in the US with chronic liver disease. For example, in this one study, approximately 3,000 individuals with chronic liver disease were evaluated. And among individuals with non-alcoholic fatty liver disease, close to 40% reported self-reported vaccination or had antibody to surface to antigen. Among individuals with alcoholic liver disease, 47% self-reported vaccination or had anti-HBs. But the complexity of multiple sequential vaccinations can be challenging, particularly in resource-limited environments. And when you look at vaccination rates and surface antibody positivity rates, they're lowest among Hispanic and non-Hispanic whites at 32 and 33.6% respectively, and highest among Asians at 60.6% respectively. And that may indicate the higher prevalence of exposure to the virus. Among patients with alcoholic liver disease, rates of vaccination and surface antibody positivity were lowest among Hispanics at 39.9% and highest among Asians at 74.6%. So the conclusions from this effort were that future efforts are needed to focus on targeted provider education or implementation of best practice alerts in the EMR to improve successful vaccination or documented immunity. So the question is, who should be vaccinated? Adults who are recommended to receive the vaccine are listed on this slide. And I'd like some input from Joe to take this information on this slide and make a few comments regarding vaccination for hepatitis B. We believe that probably everyone should be vaccinated, but certainly we want to target those high-risk individuals. Joe, do you have a comment?
Absolutely, Chris. Yeah, I think that this is a critical issue that I think that all of us bear responsibility for. we recognize that hepatitis B is a vaccine preventable disease. And from a public health perspective, it's really vital that we participate in that process at the level of primary care or specialty clinics. Most individuals at the time that they are newborn will be offered hepatitis B vaccination by a pediatrician. And there are a number of catch-up vaccine campaigns at the level of schools and universities and health professional schools as well, and by a number of employers. But the reality is that we are still not anywhere close to where we need to be in regards to immunity at a national level. And as such, there is a need, and particularly by the ACIP, specific guidance on which patients should be vaccinated. I think that the lists here are a really good lists, but the ones I want to highlight, those who are are sexual partners with someone who is hepatitis B surface antigen positive, those who have men who have sex with men, as well as individuals who are healthcare workers, most of us here on this call. The one group which I think is often left out of the shuffle and often under-recognized are those with diabetes. This is probably the least well-known recommendation by the ACIP, that all adult diabetics should be offered hepatitis B immunization. And I would just really highlight this one because it's the one that is probably the least known.
Yeah, thank you, Joe, for taking this detailed information and boiling it down to a critical nugget of information. I think a large number of our audience members care for patients with diabetes, and that's really important. I think another point in terms of recognizing the burden of disease in the US is the prevalence of chronic hepatitis B among those who are foreign-born. We initially reported this in 2012 and then recently updated the foreign-born population in the US and then compared that to the foreign-born population with chronic hepatitis B in the US. And you can see that, especially when you look at Asia, parts of Africa, and central and southern parts of North America, there is in fact a pretty high prevalence of chronic hepatitis B. And one of the points that we made in the original publication in 2012 is that although there is some awareness that chronic hepatitis B can be endemic in certain populations in sub-Saharan Africa or parts of Southeast or East Asia, in fact, we have so many more patients from Central America and the southern part of the Northern Hemisphere that in fact, even though the prevalence of hepatitis B may be lower, the absolute number of patients is still quite significant. So I think we have to be vigilant about recognizing the need to screen and vaccinate. Now, the case for universal HBV screening to close gaps in diagnosis and early linkage to care is shown on this slide. So if you look at the fact that about 1.7 million foreign-born individuals with chronic hepatitis B are in the US, and that is a substantial proportion of the total population with chronic hepatitis B, which is about 2.5 million. And yet, more than 80% of chronic hepatitis B adults remain undiagnosed, and fewer than 50% receive appropriate care. Joe, if we narrow the population that needs to be screened to foreign-born individuals, we're going to miss a lot of people. We touched on this before, but I'd like you to expand a little bit on what are other high-risk groups or at-risk groups that should be screened?
Absolutely. So I think that the data that you showed was really critical because I think it highlights that the significant majority of individuals with hepatitis B in this country have prevalent disease from immigration patterns to the US from endemic regions. And there's no question that those individuals that you are seeing in your clinic who are foreign-born from endemic regions absolutely should be screened. In a few minutes, we'll be discussing the formal guidance by the USPSTF and other organizations for who should be screened. But I want to highlight that the estimated prevalence in the United States is about 0.3%. And so in this slide, we're highlighting a few groups for whom we have some data suggesting that the prevalence may be higher, and therefore really helps you target which populations we really should be thinking about offering Hep B screening. These include US veterans, healthcare professionals, all of us on this call, MSM. There are some mixed data suggesting that this may represent a higher risk population compared to the general population. Incarcerated populations, those in both state prisons, federal prisons, those who are homeless, The persons who inject drugs, patients with Hep C or HIV co-infection should also be considered for a routine hepatitis B screening. There are other populations that are recommended by our Liver Society for routine screening as well, including pregnant women, those with diabetes or other medical disorders, and of course, newborns. On the next slide, we do highlight one group for which we have really interesting epidemiologic trends that over the last decade, there has been a well-documented opiate epidemic with injection drug use. And I think that the thing we want to highlight here is that there is a concurrent overlapping epidemic of acute hepatitis B and hepatitis C. And it is striking that as of 2016, that we have significant number of new cases of hepatitis B of nearly 21,000 individuals. And just 8 states represents nearly 2/3 of these cases, which we believe to be tied directly to similar epidemiologic trends for the opiate epidemic. And therefore, specific steps that we can take for harm reduction, screening, linkage care remain vitally important so we can identify these individuals and offer appropriate treatment.
Joe, thank you for that really important comment. Grace, a couple of practical questions from a primary care provider. Questions are already coming in, so it's exciting to see people are engaged. Can you give the hepatitis B vaccine and the Shingrix vaccine at the same time? I'm not sure there's a right answer, but wondering if you want to take a stab at that before we get into the next step.
Gosh, what's vaccines can be given at the same time are things that I always actually look up in the moment. And that also applies in the present day when we're also actively trying to administer the COVID vaccine and recognizing that there needs to be at least a 2-week interval in between.
I can tell you, having taken the Shingrix vaccine myself, you do have a pretty sore arm, and I actually had more side effects than the second dose of the Pfizer vaccine. So I would say we certainly don't want to discourage the patient from coming in and completing the hepatitis B vaccination. So I would probably separate them just so they don't associate any side effects that they may have gotten from the Shingrix vaccine to the hepatitis B vaccine. Another question about side effects of vaccination in patients who have obesity and type 2 diabetes. Joe, I'm not aware of any data that suggests that the vaccine has any significant side effects at all, let alone in patients who have obesity or diabetes. Do you want to speculate on that before we get into the next section?
I think briefly, for those who are not already familiar, there are 3 approved Hep B vaccine strains. The best known is Engerix, Recomavax, and a new version called HBsAg. The first 2 are 3 shots over 6 months, and the new shot, HBsAg, is 2 shots over 1 month. As far as the available data suggests, there do not appear to be any increased risk of adverse effects in those with diabetes or obesity, to my knowledge. And as someone who offers a lot of vaccines, I simply have not seen any indication that those individuals are higher risk of complications.
Yeah, thank you for that very precise answer. So Grace, one of the things that I've learned taking care of patients with liver disease over the years is that stigmatization, discrimination, and concerns about stigmatization are really major barriers to care. And if we don't get patients to trust us or to show up to their appointments, all the effective therapy will have a efficacy of 0. So combating stigma must begin with us as healthcare providers. What can we do to stop this? Whether it's perceived, conscious, or not obvious stigmatization in regards to hepatitis B diagnosis and treatment.
Well, thank you, Chris, for including this issue in this presentation. I think it's really important. I think all of us in healthcare have either personal experience being on the receiving end or actually having to deliver the message of a chronic disease diagnosis. And we all know that with certain conditions that this can be very difficult, particularly when it comes to hepatitis B and their perhaps cultural significance of what having this diagnosis means. And I think being aware that there's stigma associated with having a condition is a really important factor in how we treat patients with hepatitis B. And a good place to start in dealing with this issue is actually ourselves. Do we know all the facts? Are we aware of our own attitudes and behaviors? And when we speak about having hepatitis B, being cognizant of what our words actually mean. And I think this is particularly important when we've seen the data on the percentage of foreign-born and the fact that we may be having to use interpreters or language that may not be our own or the patient's own, and really being cognizant of what the impact of those words are. I think starting with ourselves and then working with our healthcare teams to also help spread that education process and helping us to do a much better job with an awareness and a sensitivity.
Yeah, I think that's great. Joe, do you have any comments about how you, in your own day-to-day practice, sort of, earn trust or at least break that wall between your white coat and the patient?
Yeah, this is such an important issue, and I certainly don't claim to be expert in this particular problem, but I think that there's no question that it is important that we approach this at the level of where the patient is at and trying to get a sense of what has their experience been with the diagnosis, what does it mean to them in the context of their family, their workplace, their community. The stigma that's attached to this has been well documented, and there has been clear evidence of discrimination, both at the level of the workplace, education opportunities, as well as in terms of connection to building relationships as well for those who are very young with the diagnosed hepatitis B, particularly in specific cultural contexts. And so I think that trying to address this up front with the patient so that there's an opportunity for conversation about the implications and the things that we can do as a healthcare provider to mitigate that, to educate, to work with their family members so that there's no misconceptions about what it means to have hepatitis B, especially when we have effective antivirals.
Yeah, and especially given the current era and the current climate of a very tumultuous time and prejudice that's being directed against certain populations. It's really important to make sure that we earn trust from our patients and get them to come in for their appointments. And so it's important to remember that there are resources that are available to download on the CME Outfitters HBV Patient Education Hub. A lot of work has gone into this, so we really encourage audience members to download and use this information in their practice. Now, Grace, I think all three of us have a view about screening, and maybe it should be universal screening. But the USPSTF does have recommendations that we have to highlight at the present time. Can you walk us through that, please?
Sure, Chris. So as you mentioned, I think all of us as presenters would actually prefer a universal approach, but with the most recent update, which I believe was at the end of 2020, the United States Preventive Services Task Force continues to take a more targeted approach, and it's a grade B, which means that the certainty of the net benefit is moderate, or that there's moderate certainty that the net benefit is moderate to substantial. In other words, do it. And the approach the USPSTF takes is to recommend screening for adolescents and adults who are at increased risk of infection. And they define that risk of infection in the bullets that you see listed on the slide. Persons born in countries of the world with a high prevalence of infection greater than 2%. And you've all seen the maps that show where this is: Asia, Africa, the Pacific Islands, and parts of South America. US-born persons who haven't been vaccinated as infants, whose parents were born in regions with high prevalence, and that would be greater than 8%. As has been mentioned in terms of risk factors in previous slides, HIV positive persons, persons who inject drugs, men who have sex with men, and household contacts or sexual partners of persons with hepatitis B infection.
Well, that's great. Now, with regard to the changing epidemiology of hepatitis B, there's a question, and they're coming in here at a good rate. So, Grace, I'm going to ask you, about whether you've noticed an increase in hepatitis B infections. And Joe, you're welcome to comment as well. With COVID and with the surge of opiate use disorder, with limited resources during lockdown and pandemic. We know that hepatitis C infections have increased significantly. Has there been any data about hepatitis B infections acutely? Are either of you aware?
I think that we don't have very good data at this point specific to hepatitis B, and I think that reflects the fact that there's been under recognition, under testing for hepatitis B in the same way that we have for hepatitis C. So I think that there remains to be seen as whether there's a very clear epidemiologic observation for that phenomenon. There's no reason for us to believe that there wouldn't be a signal that would be in tandem with that of hepatitis C.
Although I don't have a specific reference to cite, I would be almost certain that the incidence of hepatitis B has increased, just as the incidence of hepatitis C has increased.
So I don't know of data specific to during the pandemic, but I do believe that with regards to the unfortunate opiate epidemic, we have seen data that does show that there's more acute hepatitis B, I believe, in the areas where the epidemic is having its greatest impact.
No, that's correct. So that was documented even before the pandemic. And so, I would assume that probably just with limited access to pain treatment and opiate substitution or medication-assisted treatment, there's probably a greater likelihood of individuals turning to illicit sources of drugs. And so you could potentially see how the prevalence or incidence or both might increase. So Grace, you walked us through the who should be screened and very succinctly. Thank you for that. Now let's talk about, of course, the alphabet soup. What tests should be used and in what context?
So as you can see on this slide, there have been a variety of very renowned and august groups that have weighed in on how hepatitis B screening should occur. I favor, and I believe my colleagues on this panel favor, the United States Preventive Services Task Force approach. And it's the rule of three. That's three tests: hepatitis B surface antibody, hepatitis B surface antigen, and hepatitis B core antibody. That's three. Remember, three.
Yeah, no, that's great, because I think sometimes people get overwhelmed with pre-core and basal core promoter and e antigen negative and e antigen positive. And there really is only those three tests that you need to remember. Joe, so now testing is the first step. How do you interpret the serologic tests? What if you order more tests or you're faced with a panel of tests? How do you interpret them, and where do you go from there?
Absolutely. So I think this is really important that we review exactly how to interpret these tests. And this can be a source of much confusion. And so I encourage those who are seeing these patients where there are tests that don't quite make sense to pick up the phone or send a message to one of your specialty colleagues to help make that determination. However, it's important to just review briefly what these mean. The surface antigen is the test that marks active infection, whether it's acute or chronic. The hepatitis B core antibody total suggests that someone has been exposed to hepatitis B at some point in time, again, either as part of active ongoing infection or someone who has prior history of hepatitis B. And then the third marker is the surface antibody, also known as anti-HBs. And that suggests that someone is immune to hepatitis B, either from prior exposure with resolution, with what we call natural immunity, or those who've been given a vaccine in what we call vaccine-induced immunity. There is a fourth test, which we do use in very specific clinical contexts where we're concerned about acute hepatitis B, someone that's just been exposed, where they have hepatitis, they may be jaundiced. And that test is the IgM anti-hepatitis B core. And that test is used specifically to mark for acute infection that's recent. So as we walk through some of the specific scenarios here, I want to highlight the following. Number one is chronic infection. And so what we see in this case is that surface antigen positive, which means they have active infection. The core is positive because they've been exposed. And the IgM is negative because they're no longer acute. And the surface antibody is negative because they're not immune. They've got ongoing infection. The second scenario is someone who has recovered from infection. The surface antigen is negative, they're not actively infected. The core is positive because they have been exposed, and the surface antibody is positive because they are now naturally immune. The third scenario is someone on the first bar where someone has surface antigen negative, not currently infected, core is negative, they've never been exposed, but the surface antibody is positive because they've gotten the vaccine shot. Those three scenarios are the most common and the ones that you really do need to be familiar with. There are other rare scenarios, such as when the hepatitis B core is positive alone. That's what we call a curveball, and this is what I like to quiz my fellows on. And there are specific scenarios that can be seen. This can be due to what we call waning immunity, where someone has been exposed to hepatitis B, but their protective levels of surface antibody has waned over time below the levels that are considered positive on a lab test. And those patients arguably are still protected and don't technically require a booster shot, but it sometimes can be considered. But the second scenario, which is something that usually is a curveball that does require specialist consideration here, is what we call a chronic occult hepatitis B, where there are rare situations, rare mutations, where someone could be positive for hepatitis B, even though the surface antigen is negative. And therefore, the only clue is the positive core antibody. And in these cases, we would suggest checking a DNA test to verify. This is a curveball. We do not expect that this is something you're going to be seeing very often. And if you are in one of these cases, I strongly suggest that you involve one of your specialty partners to help adjust or determine appropriate next steps.
Yeah, thank you, Joe, for a great summary. There's some really spot-on questions about at what point does a specialist need to be involved, and at what point can diagnosis and treatment be undertaken by primary care physicians. So I think what you're saying is that really in almost all cases, including in cases where patients are positive for surface antigen, primary care provider can in fact handle the interpretation, further evaluation, and staging, and we'll talk about treatment shortly, and initiate treatment. And engaging with the specialist in cases like this, where there's some nuance to the diagnosis, or of course in patients who have advanced fibrosis, where they may need a specialist to weigh in on cancer risk, et cetera, is where you really need the hepatologist. So Grace, Joe walked us elegantly through this very confusing series of positive and negative tests. And now let's look a little bit broader and pan out a little bit. And go beyond just the serologic test. As a primary care provider or primary care physician, what should be an overall evaluation of a patient who's surface antigen positive?
Sure, Chris. This is something that in our practice we do almost every day. And this slide, which is taken from one of my favorite resources from the University of Washington, Hepatitis B Online, sort of summarizes what all needs to be done once you've done your 3 initial screening tests and you have come to the conclusion that you have a patient who has infection because their surface antigen is positive. Now, before we sort of go into detail on the slide, sometimes when we look at busy slides, we get really overwhelmed and we go, whoa, I can't do all of that. And I want to assure you, this is easily handled by primary care providers. Keep in mind that when you look at some of the things related to history and examination, you've already taken the patient's history. So you're going to know about things like family history, and you've done the physical examination. So if there are concerns about perhaps the stigmata of cirrhosis, you will have seen that on the exam. So even though it's on this slide, it doesn't mean it's something new and something in addition to what you would already be doing. The issue about hepatitis A vaccine, that will not be as difficult as it looks, because when you scoot over to the tests that you're going to be doing, once you know that somebody is surface antigen positive, you'll see that actually one of the things you're testing for is hepatitis A immunity status. And you can read for yourself what all are the lab tests done and what are all the additional serologies that you need. I would want to just insert a little warning about when you're ordering additional labs, particularly the serologies. You know, those of us in the electronic health record age are kind of tired of clicking a lot. And sometimes our labs think that they're helping us by having panels. And I would sort of enter a word of caution here that you know exactly what's in the panels that you're ordering, because there are very specific tests that you need, and sometimes what's in the panel isn't exactly what you need. The last column has to do with imaging and staging studies, in addition to the abdominal ultrasound, which I think all of us know easily how to order that. There are some that have to do with staging and looking at fibrosis, and I think Joe is going to cover that. But by and large, this is very manageable by the primary care provider. It's a checklist that you need. I wouldn't expect you to memorize it, but I would bookmark something like the University of Washington Hepatitis B online guideline.
Yeah, no, great for that. Thank you for that summary. I mean, basically, we're talking about, you know, take a good history and do an exam, do routine laboratory tests to evaluate liver tests, kidney function, CBC, platelet count, etc. Look for co-infection with hepatitis C, hepatitis delta, HIV, assess the level of viral replication, and then take some effort to stage the disease. And that is where the University of Washington's website is very helpful. There's another question about this isolated core antibody. So I'm just going to take the liberty of kind of reviewing it as Joe very nicely summarized. So essentially there are two explanations, well, there are three explanations for a positive core antibody that's isolated. One, it's a false positive. If you repeat the test, you know, it's likely to be negative. It may be negative. The second is it's a true positive, and it's a true positive, then you either have a patient that previously was exposed and developed immunity, but the surface antibody titer now is below the measurable level. So that patient is an immune exposed patient. And then the second is what he was Joe was talking about, was the cryptic hepatitis B, which is quite rare, where the surface antigen test is falsely negative, but the patient actually has ongoing viremia. And so that patient would be positive on a hepatitis B viral DNA test. It's also important to remember that the surface antigen levels will drop over time, and the rate of surface antigen loss has been estimated to be about 0.5% per year. So if you identify a patient who is in their 70s or 80s, who may have acquired the virus early in life and developed chronic disease, their surface antigen may be negative. And this is one reason why those of us, such as Joe and myself, that care for patients with liver disease, will see a patient with a hepatocellular carcinoma with surface antigen negative, but comes from a environment that has high endemicity. And we suspect in those cases the patient has HBV-related cancer, but the surface antigen is just negative. So a positive core means it's either an immune patient with an antibody titer not measurable, or a patient that actually has chronic disease with a false negative surface antigen. So hopefully that helps reinforce the learning for our audience. There's a few other questions about HCC and hepatitis B, and we'll get to that in due course. So let's move on now and introduce an augmented reality segment, which is fun to watch and describes the key understanding of the different stages of fibrosis in hepatitis B and how that might impact how we monitor and manage patients. So I hope you enjoy this augmented reality segment.
Fibrosis progression is a stepwise process that goes from one stage to another. There are a total of 5 stages of fibrosis. You have initially a liver that has no scarring and no fibrosis, which we will describe as F0. F1 scarring is minimal scarring where there is initial response to injury. Over time, as scarring has progressed, it extends from one liver lobule to the next with more significant fibrosis. And then we start to get into more dangerous levels of fibrosis called bridging fibrosis, where the fibrosis forms bridges from one lobule to the next. And this eventually leads to cirrhosis or more advanced scarring. And this, of course, is the stage at which we have the increased risk of liver cancer and risk of decompensation.
Now, please remember to the audience members that if you want to share this information with your staff or with patients as a learning tool, the video is available on the CMEO website. So let's move on now and talk about the importance of fibrosis staging. I think that augmented reality segment really showed us how fibrosis progression drives clinical outcomes. And so it's very important to make an early diagnosis. Joe, as we saw in the video, staging of fibrosis is important. What are some of the methods that you use to stage fibrosis in your practice? And then I'd love for Grace to provide input from the standpoint of being a primary care provider as well. So Joe, can you please address fibrosis staging?
Absolutely. I think that this is one of the more important things that we try to do as physicians is trying to figure out where along the stage of liver disease a patient is. Patients want to know, we want to know as their healthcare provider. The gold standard 20 years ago and today remains a liver biopsy, which is an invasive test where we take a needle sample of the liver tissue. We recognize that liver biopsies are very unpopular. They're intrinsic error, inter and intra-observer variation, and therefore, we very rarely use it nowadays. I'd be very curious to hear from my colleagues how often you actually use liver biopsy. In its place, we have a number of non-invasive tools that have emerged as very useful surrogates, including both those that are based on serum indices, meaning that you basically plug numbers into a formula based on available lab tests. A second grouping are proprietary blood tests that you order through your local hospital, Quest, LabCorp, or any commercial laboratory. And a third grouping that uses ultrasound elastography, which is a technique where we use ultrasound technology to measure the stiffness of the liver and make an estimate regarding their stage of liver fibrosis. These are three major groupings. So on the right include FIB4 and APRI. And in the next slide, we're going to be showing you exactly how you go out and calculate these scores. But what you actually do is that you use just 2 or 4 variables, including age, AST, ALT, and platelet count. These are very easy because you're going to have it for nearly every patient that you care for. And so if you actually Google APRI score or FIB4 score, that you're going to find very easily online a calculator where you can plug in these numbers at the point of care as you're seeing the patient in the office and be able to get a score that you can then use to determine, does this patient of mine have a high chance of having significant damage to their liver or a very low likelihood of having liver disease? And then there's a middle group where you really can't tell either way. And the one that I personally used and what is often used by national organizations, including National VA for health maintenance purposes, is FIB4. And so we can actually look at all of our patients and determine what proportion of these patients are likely to have advanced disease. If you plug in the score, if it's more than 3.25, there's a very high likelihood your patient has stage 3 or 4 fibrosis, advanced disease, and therefore should really guide you in terms of your approach to management of that patient. Now, in the next slide, we talk through, what are the different methods and how do you go about choosing whether you go with FIB4 APRI, a serum test, or the elastography test. Now, I think that my own clinical approach is to do ideally 2 tests, either APRI FIB4 and or a serum test. The most commonly used are called FibroSure, FibroTest, HepaScore, FibroSpect, among others. And then among the elastography techniques, by far the best known one is called FibroScan, which is a point of care ultrasound-based tool that takes 10-15 minutes to measure liver stiffness. Now, I think that my own approach is preferably to use 2 tests, some serum-based test, and elastography. And it really is going to depend on what's available to you in your practice. So if you are in an area where you have access to FibroScan or radiology-based elastography, such as ShareWave, by all means, take advantage of what's available to you. But the principle that I would suggest is that usually using 2 different methodologies is going to lead you to the truth more times than not. So I'm curious about Dr. Kowdley and Dr. Wong.
Yeah, so I'll give you my input, but I think it's going to be probably most important to hear from Grace, because you and I, Joe, we are privileged in that we practice with access to, I have 2 FibroScanners in my clinic. We use MR elastography and whatnot. And of course, liver biopsy. I was trained by Dr. Marshall Kaplan, who was trained by Dr. Klatskin. So from your institution, who was a legendary figure in hepatology. And so I never found a liver that I didn't want to biopsy. So we're privileged. And so I think it's important to say, if you're a primary care provider and you don't have access to a FibroScan, what should you do? I think the first point is that FIB4 is free. You don't have to pay $500 for a proprietary test. But, the proprietary tests such as FibroSure and whatnot can be very helpful, and they're covered by insurance in most cases. The combination of the ultrasound, platelet count, and FIB4 and APRI, I think will give you the information that you need to exclude advanced fibrosis in the vast majority of cases. If you have access to an imaging-based test such as ultrasound elastography or MR elastography or FibroScan, that may be helpful in equivocal cases. And every once in a while where we're thinking that there could be NASH along with hepatitis B, or the patient has a low viral load but high liver enzymes, which is sort of inexplicable, then a biopsy can be helpful. So that's sort of my approach, very similar to yours. But Grace, how often in your practice or in a practice do you think that a primary care provider would need to say, I really need an imaging-based specialty test that I cannot calculate from a FIB4, APRI, platelet count, and ultrasound? I would think it would be rare. It would not be common.
So I think you answered your own question. So in my own practice, we can order the FibroSure, but as you point out, even though it's covered by insurance, in some cases, depending on what the deductible is, there can be out-of-pocket expense. So the calculators that actually, as Joe pointed out, are with lab results that you already have are probably the most common ones that we use, although I do use the FibroSure. It is possible in a primary care practice to be able to do the elastography, but as you point out, those are rare. One, because there is expense to the program to have the equipment, and then you also need to have someone who's trained in how to do this study on site. I do know of some at least one community health center that has a high volume of hepatitis B patients, and they do their own on site. But you are correct. It's more often that in primary care, we use the more serologic based ones.
Yeah. So one of the things that we learned from the Hepatitis B Research Network, of which I was one of the principal investigators while I was at the university and Virginia Mason, is the fact that the metabolic profile of people who immigrate to the United States starts to look more like people who were born in the United States. And so we have, the growing population with metabolic syndrome, central adiposity, hypertension, hyperlipidemia. And then we have the modifiable risk factors such as smoking and alcohol use. And these probably are very important in driving progression and increasing cancer risk. Grace, how do you have a limited amount of time. Many of our primary care providers have 15 minutes to see a patient. How do you counsel patients with regard to lifestyle modification in the setting of hepatitis B as a risk factor?
So, Chris, you're absolutely right. We don't have as much time as we would like to spend with our patients, but I think there are ways to get the job done and to do it well. I think one of the things to think about is who else is on the team who could help out. And, depending on the type of practice you have, you might have someone like a nurse or a medical assistant who has a special interest in being trained up to do the patient education and counseling. I think the overall message that's really important when you are with a patient who is being diagnosed for the first time with hepatitis B infection is that they can live a full life. And with proper prevention and healthy habits that Dr. Cowley has mentioned, that is something that we work with them to promote. You see here on this slide a series of bullets that we took from some of the education that is available through the Hepatitis B Foundation in several languages. And you'll see that it's a very holistic approach. It combines things like things that you would do for overall health anyway, like regular visits with your healthcare provider and paying attention to what you drink and what you eat and getting regular exercise. But there's also some specific things that center around prevention and also protecting the health of your loved ones. And those would be things like vaccinations for yourself and screening and vaccinations for sexual partners. I think the other thing to remember is that, as with other chronic diseases, we're seeing patients over time. So, trying to cram everything into one visit is never effective anyway. I think all of us know that we reach our limit, and sometimes things that go in one ear come out the other when there's a whole list of things that somebody is trying to go over with you. And so actually spreading it out over time is another thing that you can do if you don't have somebody in your practice who can help you out with the education.
Yeah, no, that's great. I think to do it in sequence, first to establish the diagnosis and then to go on with the risk assessment would be good. So let's move on to our second learning objective and discuss how we can optimize treatment for patients with hepatitis B. And so optimize efficacy and safety profiles of current agents when initiating or switching treatment in patients with hepatitis B. And with that, let's start with a polling question. There's no right or wrong answer here, but we'd like to get a feel for your current practice. 56-year-old male patient is screened and is noted to be surface antigen positive and E antigen negative. ALT is 90. HBV DNA is 3,200 IUs per mil. What is your next step? Initiate treatment, refer to a specialist, monitor and check again in 6 months, or I'm not sure. Okay, so we have the results and we see that 25% said initiate treatment, 33% referred to a specialist, 25% monitor and check again in 6 months, and 4, I'm not sure. All fair answers. Grace, what is your take on this, on the responses?
I think they reflect probably where you are and your level of experience with providing care for hepatitis B and what is readily available to you to do that. I think we're going to be going into detail in future slides on how to interpret some of this data that shows up for this particular patient. But I appreciate the honesty. And, for those of you who answered number 4, knowing where you are is the best place to start. And I appreciate that.
Yeah, no, that's great. And hopefully if we're effective here, the 33% that said refer to a specialist, maybe more of them will feel comfortable doing the next step themselves. And in fact, a very significant proportion here felt comfortable to monitor and to start treatment. So 50% of our audience already feels empowered. And I think this brings up the issue of a national strategy for elimination of hepatitis B and C. The AASLD and the IDSA has actually proclaimed that we should partner with primary care providers and their professional organizations to build capacity for treatment of hepatitis B and HCV in primary care. And for medically complex patients, referral systems should be set up. So it's not just the primary care provider should be handling all treatment going forward. Primary care providers have enough to do already, but partnering so that we can have a seamless transition and true collegial and collaborative approach to these patients to allow them to be treated where they are instead of where we are is key. Project ECHO is an excellent example of bringing the treatment to the patient, then bringing the patient to the ivory tower, if you will. I can certainly tell you that for many of my patients, just the idea of finding their way to the parking deck and paying for the parking is already prohibitive. But I think we've got a nice transition point here where we've talked about screening, vaccination, and diagnosis. And now let's move into treatment so that we can all feel comfortable with treating patients going forward. So the goals of treatment are to achieve sustained suppression of hepatitis B viral replication. That's the first goal, because it's clear that patients who have viral suppression have better outcomes. And ultimately, we want to decrease the morbidity and mortality related to chronic hepatitis B by reducing the risk of progression to cirrhosis and liver-related complications, including liver cancer, and ultimately improve long-term survival. So Joe, here come the famous phases of chronic hepatitis B slide. Can you tell us about these phases very briefly and how they dictate treatment decisions?
Absolutely. I think that this is classically one of these slides that creates a lot of confusion for primary care and specialist clinicians alike, and largely because I think that the definitions often have quite a bit of overlap, and there are many patients who don't neatly fit into what we consider distinct phases of chronic hepatitis B. There are 4 phases that represent the natural history of chronic hepatitis B infection, and this is distinct from stages of fibrosis, just to make that clear. Now, typically when someone is initially infected, whether it's at birth, from mother to child, early adulthood, or otherwise, usually have what's considered a wild-type virus with E antigen positive or E positive infection. Once you have E positive infection, there's a period of time where you have what's called immunotolerance, which means that that the immune system is not reacting to the virus. The DNA may be very high, but the ALT is normal. There's no evidence of inflammation. And if you were to do a liver biopsy in that patient, you would see almost no damage to the liver whatsoever. These patients do not require antiviral therapy. In the second phase, it's what we call immunoactive phase. There is a spontaneous transition from that first phase, where there's no damage, to the second phase, where in addition to the DNA being very high, that there is an active immune response with high ALT. And in this period, there is significant liver injury taking place. And it's during the phase that it is ideal that one of us as a clinician would identify this and initiate antiviral therapy so we can address this issue and halt ongoing immune-mediated liver injury due to hepatitis B. In this phase, the E antigen is positive, DNA is high, and the ALT is high. And this is a primary phase in which antiviral treatment is recommended. Now, whether it's induced based on antiviral therapy and its success, or due to spontaneous recovery from the E antigen immunoactive phase, that there's a spontaneous transition to where it goes from E antigen positive to E antigen negative. Now, this often is associated with specific mutations, which is not a focus for today's discussion, but these include what's called the pre-core or the basal core promoter, BCP mutation. And this is a naturally occurring event that typically occurs a couple decades into one's infection. And so if someone already has E antigen negative infection, that typically implies that someone has a long-standing infection of typically at least 1 or 2 decades duration, although there are exceptions to that rule. Now, in this transition to E antigen negative infection, that's what we often call the inactive carrier phase, in which the E antigen is negative, the DNA is low and even undetectable, and the ALT is normal. This is a very quiet phase where there's no active damage to the liver, and therefore no treatment is required. Monitoring is what's recommended in these patients, typically twice per year with labs. And in this population, many of these patients remain inactive for many, many years. Unfortunately, this has often been called a benign carrier. Unfortunately, there's nothing benign about this phase because we recognize that by definition, they've already gone through that second critical phase of infection where significant liver damage may have already been sustained. And therefore, monitoring of an inactive carrier is required. A subset of these patients may undergo spontaneous reactivation of their infection where the DNA goes from normal or low or undetectable back to very high levels, and the ALT becomes very high again. And in that scenario, we would recommend antiviral treatment. Now, this can also be induced by immune suppression due to chemotherapy, other biologic agents, or diseases that suppress the immune system. But the idea is that regardless of the etiology, the reactivation is also known as the immunoactive phase. And as such, the second phase, that's E positive, and the fourth phase, that's E negative, in a sense, are both immune active phase infection and represent the target for antiviral therapy. First and third phases can be monitored. Second, fourth phases are the target for antiviral treatment.
Great. Thanks, Joe. We have a lot of questions about treatment, and I want to focus on that, get to that quickly. So, Grace, do you have any comments? When you look at the treatment guidelines, they can be kind of confusing. Is there an efficient way to look at when you start treatment in a couple of sentences?
Yes, bookmark University of Washington Hepatitis B online. Seriously, we can't all have easy access to people like Dr. Cowdley and Dr. Lim. And if you're trying to decide what to do, I love this particular table from Hepatitis B online, which really helps you to figure out what to do based on 3 factors: the presence or absence of cirrhosis, what the hepatitis B viral load is, or the DNA level, and the level of the ALT. And then you'll see, based on whether or not there's cirrhosis, what the level of the DNA is, and what, if the ALT is normal or not, what you should do. And so if you hearken back to the little quiz that we all got, you'll see that actually the person who was presented had, I believe, no cirrhosis, but a viral load greater than 2,000 and an elevated ALT, which would put them in the category of treatment. I won't go into more detail because I know we all want to get onto treatment, but you'll see from this table, it also gives you very helpful advice on what to do next, which I think is a common question we ask ourselves when we get the data that we get when we order our labs.
Yeah, no, that's great. And we certainly can elaborate if needed when there are specific questions. But I think the way you've laid it out is great. Determine if the patient has cirrhosis, determine their viral load, determine their liver enzymes, and then that will help you make a decision about treatment. So one of the things that often happens, and it's very confusing to primary care providers, is what is a normal ALT? So let's test the audience. The ACG guidelines say normal ALT is which of the following? Grace, what are the normal limits for ALT for adults? The correct answer, by the way, here should be 25 for women and 35 for men based on the ACG guidelines. So now that I've given the answer,
thanks.
Tell us why and how.
So, as primary care providers, we, I think, have been trained to work really quickly. And I think the important piece to take home here is that there's a difference between what your lab tells you is the normal range and what is actually a normal healthy liver. And you know that when something is out of the normal range, most labs will then have the result change color. So we're all used to scanning for red, but in this case, don't look for red, look for the actual number. And if in a woman it's greater than 25, and if for a man it's greater than 35, then remember those are important cutoffs. And you'll see from the bullets how important that is, particularly the last one where you see there's a linear relationship between ALT levels and BMI. And we know that we're talking about increased risk for fatty liver. I also think it's important to recognize that a normal ALT level may not exclude significant liver disease, because I think there are cases where when liver function has been so infected that when it's low, that's also something where you need to worry about as well. But if you're going to remember 2 numbers, it's for women 25 and for men 35.
Great, very clear. So now we, let's say we've identified a patient whose ALT is greater than 35, has a viral load greater than 2,000, doesn't have cirrhosis based on a FIB4, say, of 1.5 or 1.0. And so now we want to initiate treatment. Joe, what are the key treatment options for hepatitis B today?
Yes, I think that we're very fortunate that in 2021, we have a very effective oral antiviral therapies for hepatitis B. And so there's really 2 main drugs, one of which is entecavir, and the other is tenofovir, which is available in 2 different formulations. Both of these medications, entecavir and tenofovir, are oral pills, 1 pill once daily. Both of them are very well tolerated and generally have very good efficacy regards to the primary goal of hepatitis B treatment, which is to suppress the virus to low or undetectable levels. In turn, our goal is that with suppression of the virus, we can reduce the risk of liver complications, such as cirrhosis, liver failure, and liver cancer. And so to this effect, both of these medications, if is indicated, can be very effective in improving clinical outcomes. The choice of which antiviral should be chosen for your patient will depend on a number of factors. For the majority of patients, either of these will be very reasonable. However, for patients who are women of childbearing age, we generally prefer tenofovir because we have a little bit more data confirming its safety if that woman were to become pregnant, and therefore may be particularly important for patients that you care for who fit that categorization. In addition, for patients who have baseline kidney abnormalities, there is a general preference to use either entecavir or the TAF version or formulation of tenofovir because we have stronger data confirming short and longer term kidney safety. And so we have provided for you this slide that provides a little bit more nuance to that treatment decision. And if there are cases which don't neatly fit these categories, that's a great time to involve a specialist.
Yeah, no, that's a great summary. So we talked earlier of the importance of staging for fibrosis. Based on the stage of fibrosis, what are the recommendations for treatment?
Well, I think that one of the key considerations as you decide whether to treat or not, again, is based on whether they have high DNA and abnormal ALT. But our current guidelines do suggest that for patients who do have cirrhosis, that nearly all those patients should be offered antiviral treatment, regardless of DNA and or ALT. Now, the choice of antiviral, generally speaking, regardless of whether they have compensated cirrhosis where their liver is still working well, or those who have liver failure or decompensated cirrhosis are the same. Either entecavir or tenofovir can be used. Now, the only drug that we haven't mentioned until now is pegylated interferon, which is a very rarely used injection-based therapy that's treated for a year because of the safety profile and the toxicity, which can actually exacerbate liver decompensation. That is the specific medication that we would avoid in patients with liver failure.
So there's several questions here, and our audience is very smart because they keep up on the literature. One person must have just read your article, saw the publication on co-infection of HIV and HBV contributing to cancer, and why it's important to keep HBV suppressed. Can you make a few comments about that?
Sure. I think
congratulations on the publication.
Thank you. I think that although there are a number of studies that have tried to address this issue, we are very aware that those who have hepatitis B and hepatitis B HIV co-infection are not always the same with regards to the risk of liver complications. And the idea is that those patients who are on antiretroviral therapy for HIV, usually one of the components, such as tenofovir, is also effective for hepatitis B. And we now have data confirming that the antiretroviral can be effective in decreasing the risk of liver events due to the hepatitis B component of co-infection. But that risk does not go down to zero. Even despite adequate viral control of both HIV and hepatitis B, there is an ongoing risk of liver cancer. And that's the point, is that even in patients that you're treating with antivirals where it's working well, the virus is suppressed, we need to continue monitoring for liver cancer appropriately.
With regard to switching from TDF to TAF, Joe, as people age, we need to think about overall health, risk for osteoporosis among women and men. Are there differences between the agents related to the impact on bone health that might make switching from one to the other, specifically from TDF to TAF, a good choice?
Absolutely. This is an important issue that we are recognizing as there's an aging phenomenon with a lot of our patients with chronic HBV. And we know that in the general population with hepatitis B, we've actually studied this issue. There's increasing prevalence as patients age of bone disease, kidney disease, other metabolic diseases. And the reason why that's important here is that we know that TDF, which is the Viriad formulation of tenofovir, is associated with a very, very small risk of kidney abnormalities, typically in 1 to 2% of patients, and a subtle but meaningful decline in markers of bone mineral density. Although this is usually thought to be of very little clinical consequence, especially in young patients who are otherwise healthy, that this may have some relevance, especially in older patients or those who have other risk factors for kidney or bone disease. So in these two slides, the first one suggests that in patients who are already on TDF tenofovir, those who switch to TAF formulation of tenofovir, that you can see basically an evening out or a matching of their bone mineral density based on hip and spine markers, suggesting that basically you are basically at the same in terms of minimal impact on bone health in patients who are switched between these two agents. The key message here is for patients where there's any concern based on age or other risk factors for bone issues, that TAF tenofovir is the preferred formulation. In the next slide, we talk a little bit about changes in kidney function. The message is the same. Even with TDF tenofovir, the risk for kidney abnormalities are exceptionally small. But for patients who are older or who have other risk factors such as diabetes, hypertension, and the like, or who already have chronic kidney disease, that is generally seen here based on the data that either at baseline or those who are already on TDF tenofovir, that switching to the TAF tenofovir can have meaningful improvements regards to renal parameters.
Great. Let's move on to our third learning objective. And here we're going to discuss routine monitoring of patients with HBV for liver cancer. And if we have time, we have a case that we're going to discuss on HBV reactivation. So Grace, let's start with risk factors for cancer associated with hepatitis B.
Sure. So on this slide, you'll see that the factors are in 3 categories. There are host factors such as age, sex, family history, and comorbid conditions like diabetes and obesity. There are also environmental factors that have to do with unhealthy habits like smoking or alcohol use, as well as aflatoxin exposure. And then Joe, could you elaborate on the viral factors, please?
Sure. Yeah, I think that we recognize that risk for liver cancer is not all created equal. And you highlighted some of the most important, including family history, which has a striking impact on risk for liver cancer in the individual that you're caring for. But we know that there are different genetic strains of hepatitis B, hepatitis A, B, C, D, F, G, H, K, all hepatitis B. And we know that the specific ethnicities and our countries of origin are associated with very specific genetic strains. Among East Asians, as an example, there's the highest prevalence of genotype B and C. Genotype C in particular has been associated with a higher risk of liver cancer, and therefore may be used by some clinicians to help guide whether you start to screen for liver cancer at an early age and how frequently. And I think that's the other factor that's not mentioned here, but I'll just mention is that those patients that have hepatitis delta co-infection of hepatitis B are likely to have a higher risk of cancer as well.
So the indications for surveillance for cancer in HCC are sometimes confusing. Grace, can you highlight what the indications are?
Sure. So first and foremost, anybody with cirrhosis, even those who seroconvert, should have hepatocellular carcinoma surveillance. And as Joe has already mentioned, even in the absence of cirrhosis, if they have hepatitis D co-infection, anyone with a family history of hepatocellular carcinoma, females who are of Asian descent, who are older than 50 years of age, and Asian or Black or African descent males who are older than 40 years of age. And what we use is liver ultrasound with or without alpha-fetoprotein, and this is done twice a year. You can also see that there sometimes may be an indication for more frequent monitoring or perhaps using another imaging modality such as CT or MRI if something appears that is of concern. So Joe, I have a question for you. sometimes my patients have qualms about having too many blood draws. And so one of my ways of trying to reassure them that I'm minimizing that is to say, well, in this case, when we're doing the screening for hepatocellular carcinoma, I'm just going to do the ultrasound every 6 months. What do you think of what I'm doing?
I think per guidelines and based on what we know in real world clinical practice, that's very reasonable. I think ultrasound is what is recommended by all organizations. I think AFP can be useful, and I think I certainly use AFP routinely in my own clinical practice. But the reason that we don't use it in isolation is because 1 out of 3 liver cancers do not even secrete AFP, and therefore you can have someone with cancer with normal AFP, and therefore ultrasound is the appropriate screening tool. AFP can be useful as an add-on, especially if the levels are very high, which can be seen with active cancer.
Great. So I want to make sure we have time to get to more questions. So let's move fairly quickly through this case study, which has a number of questions, but very informative. Joseph, cases are a good way to work through decision-making. Can you tell us about this case that you recently published?
Sure. I'll try to be succinct here, but this is a gentleman who's 62 years old with a history of T-cell lymphoma and presented to the hospital for EPOC chemotherapy, which includes etoposide, doxorubicin, among other chemotherapeutic agents. And it was found to have abnormal LFTs, and they were admitted to the hospital. He didn't have a lot of other comorbidities, no tobacco or alcohol, no known history of liver disease. And they checked a number of baseline labs at the time of chemotherapy, and his Hep B surface antigen was negative. His surface antibody was negative. His core antibody was positive, and the IgM core was negative, suggesting that he didn't have acute hepatitis B. And this actually is a great case because this talks about the isolated hepatitis B core, which suggests that this person likely was exposed to hepatitis B in the past. His liver enzymes were within normal limits, but they were some elevations that are mild, noted just prior to cycle 5, and actually normalized at the completion of the cycle. Now, 4 days prior to being hospitalized, the physicians noted that the LFTs went up high. ALT was 131, AST 115, so that's about 5 times normal levels. And 3 days prior, he had completed antibiotic course with amoxicillin for tooth extraction. And so by the time he came into the hospital, his liver enzymes were sky high, over 500 for ALT, but his bilirubin and alk-phos were normal. So the question is, what is the most likely diagnosis? All right, so I think that this is a great group here. I think that one can make arguments that this could have been drug-induced liver injury, although time course of rising LFTs actually preceded the initiation of an antibiotic course here. And obviously, this is a CME program for hepatitis B, and so you can probably guess that we're talking about a case where someone in the course of immune suppression went through reactivation of hepatitis B. And so the key clinical take-home point is that patients who have had either ongoing hepatitis B or those who have resolved their hepatitis B with just with the core are potentially at risk for reactivation of hepatitis B. So the next question here is, should Gerald have received antiviral prophylaxis prior to initiation of chemotherapy? All right, fantastic. So I think that this is an area where there's a lot of variance in approach clinically. And so the correct answer here would have been number 4. This is kind of a curveball because in most cases, this is someone that we would offer antiviral therapy. And so I think that if you had answered yes, you would have been correct. But the issue is that so in question number 1 or answer number 1, it states that the reactivation risk here for this patient would have been greater than 10%. It turns out that in this case, the risk would have been considered moderate, which is 1 to 10%. And so answer number 1 is not correct for that reason. Number 2, any patient receiving chemotherapy with prior HBV should receive prophylaxis. Per current guidelines of the AASLD and ASCO, which is the American Society for Clinical Oncology, there is no recommendation for routine Hep B prophylaxis in all patients undergoing chemo, but for select cases when they're going through specific chemotherapeutic regimens, such as rituximab with anti-CD20 therapy and other classes of chemotherapy. I would suggest that you refer to these guidelines so that you can know in which cases that antiviral prophylaxis may be warranted. In this case, because of the doxorubicin component of EPOC chemotherapy, this person would have been placed in the moderate risk group, 1 to 10%, for which antiviral therapy would have been recommended. So after the hospitalization, chemotherapy was withheld, serology performed, and they did see this person reactivated with positive surface antigen. The viral load was over 1 million with log 6.28, and ultrasound was otherwise unremarkable. But this basically confirms the presence of Hep B reactivation. So which of the following is the best choice of antiviral for treatment of hepatitis B reactivation? All right, fantastic. So I think that the message is clear that entecavir and tenofovir are preferred first-line therapies for hepatitis B, and likewise are the drugs that are recommended for the treatment of hepatitis B reactivation. We would never use interferon in this context.
Thank you, Joseph. That was a great case to illustrate the steps you went through with this actual case report. And certainly, if it seems a little overwhelming, I would encourage the audience to recognize that you're not going to be making that decision about which patients to put on antiviral prophylaxis alone. It's going to be along with the oncologist, rheumatologist, hepatologist, etc. The key is to know the patient's status, to know whether you should consider prophylaxis for that patient. And so screening, surveillance, and monitoring is really where the primary care provider comes in, because we defer to the primary care provider to be that person who is a quarterback for the patient's healthcare. Are we seeing more reactivation than in the past?
I think
Joe?
that so I think based on national data, we have some indications that suggest that, in fact, that the incidence of reactivation is increasing, which we believe to be attributable to the increasing use of biologic therapies across a number of disease areas. So beyond cancer chemotherapy, they're more commonly used for other immune diseases in dermatology, rheumatology, and GI, including IBD. And so we are seeing these cases. And again, as you stated, I think the key is screening, basically making sure that in patients who are going through any biologic or immune-suppressive drug therapy, just check their Hep B status. And then if any of these markers are positive based on the core antibody and or surface antigen, that is a patient that really should be seen by a specialist to help guide whether antiviral prophylaxis is indicated.
Thank you. Grace and Joseph, this has been an excellent discussion. Before we head into questions, if we have a time for a couple, let's summarize our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. That is, we hope the audience will take from this presentation that apply aspects to your own practice. And these include: identify at-risk individuals in your practice and screen for HBV. Share resources for dealing with stigma and discrimination with patients and the healthcare team. And remember that most patients with HBV can be treated and managed in the primary care setting. Initiate regular monitoring and surveillance for HCC, and heighten awareness of HBV reactivation in patients who are receiving immunosuppression. We've received a number of questions and we've answered a number of them already, but I have a question for Grace. How do we counsel patients who have hepatitis B about, their risk of transmitting it to their loved ones or people who share the house with them, et cetera? It sounds like that's an area of some concern.
Yeah, and that's a really important part of education that, first and foremost, we need to make sure that the household and sexual contacts are screened and vaccinated. And then we also give advice about not sharing toothbrushes or razors, not sharing things like glucose testing equipment, what's the proper way in terms of using universal precautions to clean things like blood spills, and also, of course, not donating blood, organs, or sperm.
That's great. Another question for you, Grace. If a patient is vaccinated, what do we tell them about how long the vaccine lasts? And how do you approach a patient that has a history of vaccination, but his surface antibody is not measurable?
So my understanding is that after the 3-shot series, there is no reason to do testing for the antibody. However, we do know that in healthcare settings, that is something that many, probably all organizations require. And so I think some organizations, even with proof of the immunization status, if the antibody is not measurable, may require that the healthcare worker have another set of shots.
So, Joe, in a patient with viral suppression of hepatitis B on TDF, would you switch to TAF to minimize risks of kidneys and bone health? I think the answer there would be based on their underlying risk factors, or would you switch routinely?
Yeah, that's a great question. And obviously, my own clinical practice has been that I generally would have a preference to switch patients who are on TDF to TAF, but it really comes down to a conversation with your patients, shared decision making. But the cutoff usually is that once someone gets into their 50s and or if there are any new risk factors for bone or kidney disease, that's at the point in time where I will have that conversation and suggest that transition. But in general, our newly diagnosed patients, I have a preference to use TAF rather than TDF. One of the major barriers in some cases is just insurance coverage, and I know that that's something that can be challenging for some patients. But the idea is that generally as a preference, I would use TAF over TDF either for initial therapy, and for those who are on TDF, I have a preference to switch them to TAF.
There's a great question for both of you. This is a very erudite audience. It's reading their literature. So I read an article last night suggesting that daily aspirin can reduce risk of HCC in both hepatitis B and HCV patients. Is this true? Do the risk of GI bleeding, variceal bleeding outweigh the benefits? Any evidence that aspirin is useful in other types of liver diseases? What's your recommendation about aspirin for liver disease? And then maybe we can also have comment from Grace on statins.
I'll start on the aspirin issue. I think that we've long observed that aspirin and or other NSAIDs have been shown to have beneficial effects for a number of cancers, colorectal cancer included, and now more recently for ACC. But these are based on epidemiologic studies, looking at large cohorts of patients, looking at signals or associations, rather than prospective controlled trials. And I think that although I think that conceptually there are reasons why biologically we think it could work, I certainly would not recommend its use for this purpose. Conversely, for patients who otherwise meet criteria for aspirin, it's safe to use in a patient with hepatitis B with or without cirrhosis, and it may even have some potential benefit. And I would have similar comments for statins, which I'll defer to my colleague, Dr. Wong.
Yeah, Grace, do you want to talk about the statin? Primary care providers often get scared of statins in patients with elevated liver enzymes.
So, first of all, we should use them. And we need to remember that you can have more than one thing affecting your liver at a time, and that actually having fatty liver is also something that can be of concern, and having fatty liver and hepatitis B simultaneously would be things that we would want to monitor, but definitely, if indicated, statins should be given.
Great. And then last question with a brief answer, Grace. Pregnant woman with a high viral load and normal ALT, when should they start antiviral therapy to prevent transmission to the fetus?
Dr. Lim?
Okay.
Oh, sure. So I think that's based on our current guidance, that it is important to screen mothers for hepatitis B routinely, and those who already have a diagnosis, you want to check their DNA level at the end of their second trimester or the beginning of third trimester. If the DNA is more than 200,000 IUs per ml, antiviral therapy is recommended through the end of the third trimester, plus or minus 12 weeks after delivery. So the key time point is the end of the second trimester, checking the DNA.
Okay, yes or no answer to this one. Last question. Should patients who are on immunosuppressive therapy who are not immune to hepatitis B be vaccinated? Yes or no?
The short answer would be yes, for sure.
Grace?
If he said yes, the answer is yes.
That's awesome. Okay, So I think it's time to wrap up this great program. To receive CME and CE credit for today's program, please complete the post test on your screen and print or download your certificates. I'll talk to CMEO leadership about if we can provide some answers to some of the questions after the program, because their number of questions are really great, and sorry we couldn't get to them, all of them. If any of your colleagues missed today's programs, it will be archived on the Liver Disease Hub, and I encourage you to check out the hub for resources for healthcare providers, including the liver fibrosis video. And CME Outfitters also has an HBV patient education hub with a number of excellent resources to share with your patients. There's a narrated version of the fibrosis video that has closed captioning in Vietnamese, traditional Chinese, simplified Chinese, Hmong, or Korean. I really want to thank Grace and Joe for joining me today and doing all the hard work and sharing their best practices with the audience for an excellent program. And I want to thank CMEO for an outstanding job, as always, in developing this great content. So please stay safe. Thank you again for providing best care for your patients. And I hope you all have been or will be vaccinated.